I'm tinkering with the last few lectures a little bit, so they may not be quite as advertised, and we may use one for a slightly different purpose at the end. We'll just see how it goes. Now, today I've run a couple of topics together. I want to talk a little bit about pancreas, which is fun, and that follows on from where we were yesterday when we were talking about the role of pancreas in digestion, specifically the production of enzymes, and we mentioned briefly the production of bicarbonate to neutralize the acid from the stomach. So I'm going to start with pancreas and go on to talk about how its functions are regulated. Now, in fact, you have all the components for that. You know all the bits. It's just a matter of putting them together in a slightly different order. So that will be relatively straightforward. And then we'll talk about a little bit about liver and gallbladder function, and there's a fair old list of functions of those. We shall not spend very long on some of them because we already have dealt with some of them in other contexts. For example, the production of proteins. We know about the proteins in the body. We talked about those before, and so it'll only be a question of bringing some of that to the front again. And then we'll do a little bit of pathology here and there. We'll have a few gallstones, bile stones, and we'll have a little bit of screwed up cholesterol metabolism and see where that leads us. And the animation for this one really works, and it's ever so cool. Now, I've got it fairly late in the lecture, so it might turn out to be the last slide. We shall get there if it kills me. Right, so pancreatic function first. I'll put up the liver gallbladder outline again when we get to that bit. Here's a review. You've seen this slide before, so no need to panic. I remind you that the pancreas lies just below the stomach. Oh, God, that's a good cough. Gosh, I thought I was good. Right. I remind you that's where the pancreas is. It's the sort of question I see the anatomists love to ask, questions about the relations of the pancreas and which side of this and that everything goes. But there it is. It's got endocrine and exocrine portions. So there's the exocrine portion secreting into the duct. That's what exocrine means. It secretes out, exo, like exit. Secretes into the duct. That produces the enzymes and the bicarbonate from the duct cells. The endocrine portion, there is the ACNR cells there around their little liver. The endocrine portion, these scattered little groups of cells called islets, the pancreatic islets, they secrete into the blood. They sit around, they have blood capillaries. There's a little bit of one visible there, very small, so that's all you see. Capillary there, they secrete, each cell secretes into the blood. They secrete in, endo, within. So distinguish carefully. That's not an allowable error. There ought to be a hanging offence. But there you go. The hormones, which we'll talk about in the next lecture, insulin and glucagon, and we're concerning ourselves with those enzymes and bicarbonate today. Right, and this is a classic feedback loop. You know about this, we have all the bits. All you need to add to this is the name of the hormone. So the stimulus is acid in the duodenum. Now, clearly it's a negative feedback loop. The effect you want to get is to eliminate the acid in the duodenum. So secretin is released from the duodenal mucosa, from the wall of the gut. It's a hormone, so it goes in the blood, and it eventually reaches the pancreatic duct cells, and that causes bicarbonate solution from the duct cells to be released into the duodenum. That neutralizes the acid, and that switches off the feedback loop. Bingo. Easy. I put it in writing on the side for those of you who prefer writing to pictures. Different learning modes, don't you know? And then I've got a little list of other effects. Now, the other effects are, there are 4 of them. 3 of them are blindingly obvious. If you want to neutralize acid in the gut, you want to raise the pH in the duodenum. So we've dealt with one way of dealing with it. You release bicarbonate from the pancreas. Inhibit gastric emptying. That will reduce the inflow of acid to the duodenum. So that makes logical sense. Increase enzyme secretion by the pancreas, because that will speed up digestion, presumably. And what you might not assume in the first instance, for a bit, you promote bile release, because bile is also alkaline. So it will neutralize the acid. So it fits into the logical pattern of that. So it's acid, it's alkaline, so it neutralizes the acid. What is the last of these functions, which is not blindingly obvious until you've been told it, like a lot of good things, it's trophic to the exocrine pancreas. Now what does that mean? It means it makes it better. It helps to maintain it. As the physios say, use it or lose it. So if you don't have your exocrine pancreas stimulated, it atrophies, it gets smaller, and the cells become shut down. So the more they use, the more excited they'll be, and the better they'll be. So it's trophic to the exocrine pancreas. That makes sense. Bless you. So you'll find that happens with the other hormones that we're going to look at. We're not going to do all of them as a list. But if you look at the other hormone that's involved in here, CCK, we've mentioned, you may refer to it on all occasions as CCK. It's too long to remember the full name, but if you do, it happens to tell you what its function is, if you can do the Greek. Yes, it is Greek. Chole is bile. From the old humours of the body, choler was bile. So think of choler. Choler meaning anger, that is. So choler, if that's a word you know. Choler, so choler is bile. Cyst is a bag, or a cylinder, or a bladder. So the bile bladder, kinin, it motivates it. So it causes it to contract. So same mechanism. Fat and protein products in the duodenal lumen causes CCK release from the duodenal mucosa again. So these gut cells are endocrine cells as well, or at least some of them are endocrine cells. They're specialized. Endocrine cells in the epithelium go in the blood to the pancreatic acinar cells. Right? They go to the acinar cells and they produce the pancreatic digestive enzymes, so they'll digest those and you're back to the status quo ante. Writing says the same thing in the first part, except the other effects there. Enzyme secretion primary, but bile release also. Now, its name is after its bile function. That's presumably how it was discovered in relation to bile. So that's how it got its name. In our context, because we're talking about digestion, we turn it inside out, or converse. So it promotes bile release, yes, because it's one of the stimuli is fat. So you need to emulsify the fat. Inhibit gastric emptying and secretion. We've got enough to do down in the duodenum, don't send any more. And it's trophic to the exocrine pancreas, just the same as the other one. So you can make those things up. I was actually thinking of running this as a quiz, but life is a bit short until you know how long the lecture is. So you can work out these things from first principles. Once you know what the stimulus is for the release of that hormone, given the nature of the system, you can make up the other bits. So they make quite nice little quizzy questions, if you like. Whether they make good exam questions, I'm not sure that I've tried. There are plenty of other questions about those. So, let's have a look at the liver. There's rather a lot of writing on this slide, and it's a bit small, for which I apologise, but some of it you've already seen before. The stuff on the left you've more or less seen before. We're going to talk about the plasma proteins and its role in relation to hormones. That will be brief and is in answer to one specific item in your lecture synopsis. So that's all that deals. That's the answer to that question. I'm going to talk about the lobular structure, and I think it's very important that you understand that. For those of you doing pathology later on, it has all sorts of importance there, which I shall touch on. Hepatic circulation and ascites, or edema in the abdomen, is what ascites is. I'll talk a little bit about that. And in fact, your course textbook, Sherwood, isn't particularly good on this, so I shall reference another book at that point, which I'm assuming is in the library. Don't think I've ever looked. I get free copies, don't you know? You can borrow mine. We'll talk a bit more about bile secretion and its storage, and that will lead us into the pathology of some of the jaundices, that with hepatic circulation. There are several causes of jaundice, and we'll look at them all as we go along. Cholesterol metabolism, we'll have a look at. Now that's horrendously complicated. Now you know me, I don't do horrendously complicated. I leave that to the biochemists, who I'm sure will give you 15 or 20 lectures on cholesterol metabolism, if you let them. Suggest you don't. And in a later lecture, we shall talk about metabolic regulation, particularly blood glucose and some of the other aspects That'll be most of the next lecture and probably the one after. Functions of the liver, lots of metabolic processing. Excuse me. It receives the blood from the gut and it gets first go at processing everything. So it's detoxification, processing of foodstuffs. We'll talk about those elsewhere. Excretion of cholesterol and bilirubin. We'll talk about that. It's the breakdown product of hemoglobin. Detox, degradation, plasma protein synthesis, very important. Storage of various things. I'm not going to say anything about those last ones down there. I put little stars to indicate that those functions are done by these cells which don't seem to have another name. They're called Kupffer cells. Sorry about the dead white European male. They're like macrophages. They're grabby cells and they're process cells. They're quite complex functions. So they behave a bit like macrophages. Right. Excuse me. Must be the lack of something. Detoxification, first of all. One of the things it does is convert non-ionic organic compounds into ionic ones. So that means they can be processed in a whole variety of ways, and particularly they can be processed by the kidneys, by the proximal convoluted tubule, PCT, later on. And there are specific importances in relation to those drugs, non-steroidal anti-inflammatories, and penicillin. They are secreted by that route. And that leads you to the logical conclusion that if you want to increase the effectiveness of antibiotics, you can inhibit the function of the proximal convoluted tubule. What was it we were talking about recently? Bird flu, I think. One of those things which has a specific agent for it. And they were considering it's hard to make enough of this stuff to dose everybody at the required level. So it was actually mooted. You might sort of give them something that will inhibit the proximal convoluted tubule at the same time, then you only need a quarter of the dose, so you can dose up 4 times as many people. I thought this was a good idea, because I should be about last in the queue, I think, at my time of life. You, of course, will be coming in, you'll be coming in after the 15-year-olds. There's a sobering thought. Well, I hope not that. So, liver and hormones, and one of the things the liver does is synthesize the somatomedins. Now, as that name might imply, the growth hormone regulates that, and they're an intermediate step in controlling overall growth metabolism. We may have some time to talk about that in another place. Now, the metabolism of hormones bit, if you look at your outline, it says various things about metabolism of hormones. Hormones are a chemical signal. With any signal, you need the signal to be clear. So it needs to have a clear start, and it needs to have a clear end. And if it doesn't have a clear end, then it's not a very good signal. There are various ways of cleaning up signals. The body uses most of them. But one of the ways it uses for hormones is that you get rid of the hormones. You metabolize the hormones. So hormone is secreted, it peaks, and by the time it gets to the liver, it's metabolized, so the signal is stopped. So you have an end to the effect. So there isn't a continuous level of stimulation, it's an intermittent level. With most hormones, it's intermittent. So that improves the signaling. So hormones, as with many other molecules, have a half-life, a time for half of the concentration in the blood to disappear. So it does that. Now, if you mess about with liver function, and it's quite easy to do so, repeated applications of alcohol in large measure will do that for you. Paracetamol will do it very quickly for you. If you get liver failure, when you happen to be male, one of the things your liver does is to remove endogenous estrogen. That's to say, estrogen which you produce. We all produce estrogen. So if you can't remove the estrogen because you've got liver failure, then the estrogen will have effects. So you start to grow breasts and you start to do other things, so you get the appearance of feminization. So that might be a consequence of cirrhosis of the liver, for example, and other liver failures. So you might get those things. So there's a little question, a little outcome that says you need to know about that. So there you are. You now do. Plasma proteins, we may have talked about those in another place. If you go back into the dim and distant, and you probably don't want to, back into that first week of your careers, then we talked about some of these proteins. We particularly talked about the role of the albumins, which are the most numerous proteins in the blood, in the plasma. and therefore they are the most important for their osmotic effects. So if you have a shortage, if you have liver failure and the liver is unable to produce the proteins, then you're going to get edema because you will not produce enough plasma proteins. That will reduce the colloid osmotic pressure in the gut, and that will reduce the inward flow of water back into the circulation. Therefore water will accumulate in the periphery, outside of circulation, so you get edema, swelling, especially abdominal, which is ascites. And the alpha and beta globulins are the clotting proteins, so naturally enough, if you can't produce those, you get increased bleeding time. So increased bleeding time tells you that you've got a deficiency of clotting proteins in that clotting cascade that we talked about elsewhere. And some of you will spend a lot of time talking about that. And likewise, if you don't have enough fibrinogen, you will have impaired clotting. Now, there are different tests for these different functions, and for those of you it matters, you'll come across them in their place. So that's quite a simple, those are the main categories of proteins. If we go back to blood, there was another category of proteins in the blood which doesn't come to the liver. It's the immunoglobulins which come from the white cells. So when you go back to that slide, you'll see that extra category. Right, the unit structure of the liver. Pathologists love this sort of thing. In fact, physiologists quite like unit structures. It means you don't have to consider the whole thing. You can consider an organ as made up of lots of individual units responding together, just like muscle does, like nervous system does, and so on. So, essentially you've got hexagonal columns of cells, and here's part of one of those columns. And it's got a relatively complex blood supply in that there are two inputs. There's the hepatic portal vein coming from the gut. I'll show you a bigger scale diagram in a moment. So that's bringing in the nutrients there, and that flow is from the outside of the lobules into the centre of the lobules. You've got the hepatic artery, there it is in red, like all good arteries, comes in and it brings the circulation into the same point, from the outside to the inside. That's centripetal, I think, isn't it? Yes, it is, centripetal. And it eventually all drains into the central vein. Okay, so that's the basic structure. You can see that the cells are arranged in these plates on the lines here, so you get an inside and an outside of the cell. So the inside is where the blood goes, and there is little canaliculi where the bile goes. So we'll see that in the next figure. Here it is. Here is the input side of the blood, hepatic artery, hepatic portal vein. Blood circulation inside to the central vein. So this is food and possibly toxins coming in, right? We ingest all sorts of nasty things. Toxins may come in there. So these cells at this end get first dibs. There's no expression, I don't think I've ever said that before. First dibs at all the food and all the toxins coming in. So they get affected first of its toxins. They have the higher load of stored nutrients, particularly glycogen, the storage product for glucose. So they will have more, and these will get less. And likewise, in liberation, these cells on the inside will liberate their glycogen first. So you can measure this. You can actually look at it histologically and see the glycogen in there. For pathological purposes, if it's an ingested toxin that you bring in, then you will get damage at the periphery of the lobule rather than at the centre of the lobule, because they'll be exposed to higher concentrations. So the pathologists get excited about that sort of thing. Now, you can see that the cells have two surfaces. One in contact with the blood, that's down there, and the walls of these vessels are incomplete. They are called sinusoids. Sinusoids, which means they're quite slow-moving blood with incomplete walls, so very good contact between the contents of the blood and the cells. So these are the cells that are detoxifying, dealing with the metabolites. At their basal ends of the cells, they secrete bile into these little tiny channels there. Where's the word? Bile canaliculi, a little channel. That's what that means. And they drain into the bile duct, and as we see, they're going to the gall bladder later. So that's essentially the flow of material through the liver lobule, with hints towards its pathological consequences and its metabolic consequences. So that's that. Here's the gross picture of the circulation, and I want to talk about this at this point you might think it would be better to have done it the other way around, and there is an argument for that. I'm doing it here because I'm now going to go on to talk about the consequences of changes in the circulation, and that will lead us to edema, particularly ascites, edema in the abdomen, the swollen abdomen characteristics, and also into jaundice, because there are problems there, which relate specifically to the nature of this flow and the pressures within the system, and what happens when things go wrong. So this is the gross diagram. So here's our gut down here, which is busy absorbing things. Yes, we can absorb some things over the wall of the stomach. Alcohol you can absorb pretty effectively over the wall of the stomach, but you can also absorb it through the mouth, so that's pretty handy too. So 1A, where is it? Hepatic artery, there it is. 1A is the hepatic artery, so that's directly coming in. Major blood supply. It gets a very early selection of the blood coming from the heart, so there it flows down through the sinusoids and so on. So oxygen and some nutrients, but principally oxygen. Hepatic vein, where is it? There it is, going out. Drains the liver out to the inferior vena cava and back up to the heart. So that's grand, and circulation thereafter. Then you've got the hepatic portal vein coming in from the gut, bringing the nutrients in there. So this is a low pressure system. So that's our system. And inside we've got the sinusoids. Okay, now the hepatic portal vein is a low pressure system, 10 millimeters of mercury. That's what that stands for. Did I ever tell you about the student who, when asked what blood pressure, mean arterial pressure was, he picked a number out of the air and said mmHg. And the extern said, what does mmHg stand for? Oh, something to do with hemoglobin, she said. Next. It doesn't have anything to do with hemoglobin, it's mercury. It's the other one. The unit of pressure. Millimeters of mercury. Old-fashioned, but there it is. So the portal vein, relatively low pressure, and there's a small difference between the sinusoids and the hepatic vein, the draining side. So this means if you get any change to the downstream side, that's to say the hepatic portal vein, the venous circulation, it has big shifts in fluid movement because of that low pressure difference. It means if you get any backup pressure, then you get fluid will leave through the sinusoids and then will drain into the abdomen. So that's tricky. Now that's the reference, by the way, to the other text, Byrne and Levy's text. They're all called Principles of Physiology, so the title's of no use. And that's the reference. It's only a couple of pages, so if you do want to go into this, you have it. So if you get congestive heart failure, so that's a backup on the venous side, central venous pressure rises, you get a back pressure, and that leads to transudation. There's a posh word. It means a flow across the sinusoids into the peritoneal cavity, and that's called ascites, edema in the peritoneal cavity. You can get ascites by other means. If you have cirrhosis of the liver, which is where the tissue has been subjected to repeated insult by toxins, usually alcohol in our society, that leads to replacement of living liver cells by fibrous tissue. This is normal response of the body of tissues to repeated insult. That leads to a rise in the vascular resistance within the liver, and that will create hepatic portal vein pressure up, and again, that will lead to ascites. Okay, so that's a backup, and that's a consequence of that low pressure difference. The sinusoids are very vulnerable to an increase in pressure downstream. That's in the venous side of the circulation. Oh, yes, one of the things you get in cirrhosis of the liver is you get esophageal varices, like varicose veins, swelling, weakened veins, bulging into the lumen of the esophagus. And eventually, that's probably what will kill the person if they have cirrhosis of the liver, if they get worse, because one of the things you'll do is you'll get a backup of pressure, and those varices will burst. This is seriously messy. It makes an awful mess because you bleed into the esophagus and thereafter over almost everything in sight. That's quite nasty. So, moderation, I'm afraid, is the key, ladies and gentlemen. Very boring. Right, jaundice. It looks remarkably like John Holder's eye, but never mind. I'm sure it's not. Right, jaundice. Again, Sherwood has one of these boxes on that page to draw you to that. Bilirubin is the product of hemoglobin digestion and recycling, which I'm sure the medics will hear about ad nauseam from the biochemists. For the rest of us, we only need to know that when you break down hemoglobin and you're recycling all the components, you get bilirubin formed, and it's a waste product to add. So it's taken out of the blood by the hepatocytes, and they put it into the bile, which gives bile some colour. It's a yellow pigment at that stage, but when it gets into the gut with the bile, it's modified into the brownish colour, which is characteristic of faeces. So that's why the faeces have colour, because it's bilirubin, breakdown product of hemoglobin. It's all there, folks. Some it gets into the urine, which gives urine its yellow colour, and you can test that for yourselves. If you don't drink, then you will raise the hemoglobin question. Well, I don't drink water. I mean, if you don't have any fluids, you reduce your fluid intake, the concentration of bilirubin will necessarily rise, and your urine gets darker in colour, more and more yellow. If you drink lots of fluid, then your urine gets less yellow because you've diluted it. And if the bilirubin isn't excreted for some reason, then you get jaundice. That's to say, yellow skin and yellow eye, and this is the characteristic and most obvious sign of it. The pupil of the white of the eye, so-called, shows the bilirubin in it, and it's distinctly yellow. It's quite a nice picture. That took me quite a while to find out, perhaps 5 minutes. Oh, why isn't it going anywhere? Oh, it's having a thing. Sorry about that. So let's look at the various causes of jaundice. There are about 3. And because we're in the context of the liver, we can relate where we are to the liver. So if you get hemolytic jaundice, which is one we've talked about briefly elsewhere, I think, when we talked about blood. When we're talking about the breakdown of blood cells, one of the causes of anemia is excessive breakdown of blood cells. If you get excessive breakdown, you may overload the capacity of the system to remove the product of hemoglobin. So bilirubin will accumulate and you get jaundice. That's called pre-hepatic jaundice, because the lesion is somewhere else. It's before the blood gets to the liver. So it's in the blood system, and the cells are breaking down for whatever reason. So excess red cell breakdown, the liver is simply overwhelmed. It's saturated, it can't deal with it anymore, so you get an accumulation in there. If you get liver disease, that's hepatic jaundice, then the liver capacity is simply reduced and it can't manage the normal amount of production of bilirubin, so that you become jaundiced. Okay, fine. And finally, obstructive jaundice, that's post-hepatic, so after everything's happened in the liver, downstream you get a blocked bile duct, and you will get a build-up of bilirubin because you can't secrete any bile, which is in some sense a waste product. So you've now got jaundice. So you've got pre-hepatic, hepatic and post-hepatic jaundice. Hemolytic, liver disease and obstructive condition of the bile duct. So you get jaundice reasonably commonly in the newborn. It's quite normal, partly because they get excessive breakdown. They come with a large amount or a large concentration of hemoglobin. Babies have a relatively high concentration and it breaks down quite rapidly. Many babies are a bit yellow when they arrive, and some are more yellow than others, and some require treatment. Most of the time they don't require any treatment. It'll clear itself in a couple of days, which it does. I can vouch for that. But if it doesn't, then the exposure to light will apparently treat it and speed things up a bit faster. But it's rarely something you need to worry about too much in clinical practice. Won't make any money for pharmacists because you don't treat it with drugs anyway. And physios can give them a rub anyway, it'd be good for them. Okay, scientists will simply take notes. So bile, we're now producing bile. It's continuously secreted by the liver. That a bit thin. No. Is that better? Sorry, I forgot to ask earlier. You forgot to tell me. Is that better? Yeah, thank you. You should shout at me, I forget. I get so carried away up here. Now people at the back can nicely nod off again now. It's continuously secreted. There is a gall bladder. So here's a little diagram. The liver is up the top. There's the gallbladder, it backs up into the gallbladder and it's stored there, where it can be concentrated by up to 20 times. Now, concentrating things can create problems because you can get supersaturated solutions, and if they supersaturate, then you get precipitation of various things, and you may get precipitation of cholesterol or excess bile salts, and they may form gallstones. And this picture from Netter's gory atlas, this is a single diagram which shows all the possible sites of gallstones all in one picture. If you had that many gallstones, I think you'd probably rattle. But the effect of the gallstone is, I guess it's stretch of smooth muscle. We all know what that does. It causes spasm, contraction of the smooth muscle onto a hard object. And here is our patient, characteristically slightly on the excessively cuddly side. And she gets a spasm of pain in there. You can treat that with some wonderful drug which will reduce the spasm, and she's restored to normal function, at least in the short term, until somebody gets their hands on her gallstones and breaks them up for her. You do this by lithotripsy with ultrasound, or if all else fails, a bit of keyhole surgery and whip them out. They make necklaces out of them, I'm told. But there you are. Why not? Got to use them for something. Recycling, it's good for us, isn't it? So recall that fat's in the duodenum, and that's the mechanism of release. So when you see bile, link all the bits together. Reinforce your knowledge by doing all of that. So bile concentration in the gallbladder may lead to gallstones, may cause problems. Now, this is maybe the first time you've seen something quite as complicated as this in terms of a control mechanism. It's using two hormones to regulate bile function. Now, when you come to discuss the reproductive system, you will see that this is easy peasy. Reproductive system, two hormones, nothing. 3, 4, any number you want to think of. Much more complicated, but this will do us for now. And we'll see a system when we talk about blood sugar as well. It's a bit more complicated. There are two hormones, so let's just go steadily through this. Before I do, let me just draw your attention to, this is not from Sherwood, it's from Stanfield and Gurman. I'm not even sure that Sherwood has a picture of that, or if he has, it's not a nice one. So occasionally I will pinch things from somewhere else. So if you've got acid in the duodenum, plasma secretin rises. We know about that, we've done all the intermediate steps. That affects the liver, and that stimulates bile secretion. Right, plasma secretin increases bile secretion. It's probably how it got its name. Bile goes into the duodenum, neutralizes the acid. Negative feedback loop round the outside, that's that stimulus downward. Protein products and fat in the duodenum, plasma CCK rises, cholecystokinin rises, has two effects. One on the gallbladder and causes contraction. That's what cholecystokinin means. You can see the experiment for that, can't you? Take a strip of gallbladder out, stick it in a bath, hook it to something that will record its contractions, whack this stuff in and see, lo and behold, it causes contractions. Splendid. Causes contraction, that will get the bile into the duodenum and result in the emulsification of fats, and that's your fats out of the duodenum. It will only do that, however, if you can relax the sphincter of Oddi, that's to say the sphincter which is at the end of the pancreatic duct, the common duct, where the bile comes in, pancreatic juices come in. If that sphincter doesn't open, you can secrete all the bile you like. It's not going anywhere. It'll back up. So you've got to relax the sphincter of Oddi, and that allows the entry of bile into the duodenum, and that's your emulsification of fats. That'd make a really nice little question. Why didn't I think of that? You know, you could get that because you get your bonus mark at the end for remembering the sphincter. And it's just enough steps in there. 1, 2, 3, 4, 5. Yeah, 10. Adds up to 10. It's a perfect question. Must use it sometime. So notice, we can think in terms of aims here, teleologically, aims to the reduction of acid concentration, hydrogen ion concentration, and the completion of digestion of fats in this case. Oh, look, the time is splendid. Right, let me just see how far I've got. Oh, good, we're coming up. Next slide is the animation, folks. Stay with me, it's well worth staying awake for. I'll wake up before that. We only have about 5 grams of bile, I think it is, in the body. And for when you have a meal, you actually have about 15 grams goes into the gut. Answer, recycling. There is recycling of bile salts. And this is the mechanism. And I'm going to show you this slide again if we have time to get there, because cholesterol goes with it. So there's the bile secreted, possibly by a detour into the gallbladder, secreted into the duodenum, and it's recycled by being reabsorbed in the terminal part of the ileum, the last part of the ileum. We already discovered that that was important for intrinsic factor B12 and all those things. You need that bit of ileum to do this job. So it brings out the bile salts and they get recycled. So they're going around 2 or 3 times during the course of digesting a single meal. As we'll see, cholesterol follows it, and that's important too. We'll talk about that in a moment. So 95% of the bile is reabsorbed there. So some gets through, gives the colouring to everything else. Circulating, and notice it's a feed forward, not a feedback, not a negative feedback, it's a positive feedback. Bile salts passing up from the liver to here, it stimulates the secretion of more bile salts. You know, we're working hard here, lads, can we have some reinforcements, is the message. So it goes around there. I put in brackets there, implications for gut resection. If you're going to cut out lots of intestine, try to preserve the terminal ileum, because otherwise you're going to have all sorts of problems because of that reason. Right, this is it. Are you ready? If your cholesterol metabolism doesn't work, cholesterol will accumulate in the tissues. We might have time to explain something about that in a moment. But I want to make sure to get this pretty picture in. You'll see in this animation, this is cholesterol in the subendothelium. This is a blood vessel. That's the endothelium, the lining layer. That's where the blood is. And we shall go in there and have a look. That's cholesterol. If that accumulates, that will lead to damage to the surface. It will raise it up from the supporting structures underneath, supporting in every sense. And that will cause damage to that. That will activate platelets, those little bits of cells that are involved in clotting, and you get thrombus or clot formation within a blood vessel. So I shall invite you to think about the consequences. Just before I move on, if I haven't drawn your attention, I may have done back in the dim and distant, to this website, gallstones.com. I commend it to you. There's some wonderfully pretty pictures. If you're having a cup of coffee or something, and you like pretty pictures, and some very nice animations in there. 1 or 2 I've shown you before, so I probably have mentioned it, but very pretty. Let's give it a lash. There it goes, accumulating cholesterol underneath the endothelium. So you're now damaging the endothelium away from its nutritive supports. Distance view, long, big plaque of cholesterol there. We're now going to whiz round and go inside and see what happens inside the blood vessel. Damaged epithelium has an effect on the platelets. Here's a platelet. There it is. A nice, calm little platelet going about its business, but it's now being activated. You need not concern yourselves with the signalling mechanisms, except you can see it seems to be autocrine. It talks to itself, and it signals, and it's now an activated platelet. It's now got all these lovely long processes coming out. Isn't that pretty? Yes, it is. I'm easily pleased. And there it is, it whirls around and they stick together. They stick originally to the endothelium, then they accumulate, they trap blood vessels, and they accumulate fibrin, and you have a nice big clot sitting there. Okay, did you like that? That's pretty. Okay. No, you can't see it again. Go to the site and have a look. So, what happens next? What may happen next? That thrombus could break down, or it could become detached from the surface of the blood vessel, which means it'll go whizzing off into the circulation, and depending on how big it is and how lucky you are, it will lodge somewhere, and it will cause serious downstream damage. So if it lands in your heart, you're going to get damage. Lands in a coronary blood vessel, then you'll get myocardial infarction, damage to the heart muscle. If it lands in your brain, you now have a stroke. We have lots of little strokes all the time. Most of them don't do any serious damage, but if you get a big stroke, or it happens to affect a really important bit, then you have a major problem. If it happens to lodge in the lung, then you can write off a large chunk of the lung very quickly. So the bigger the thrombus, once it's detached, it becomes an embolus, and if it's a big one, then it can block big blood vessels, large amounts of damage, and quite possibly fatal. If it's a small one, It's a warning sign. You might get away with it without too much myocardial damage or without too much brain damage, but you have to deal with it very quickly. So detached clots or emboli whiz around and they will block vessels. Myocardial infarction, stroke, or possibly pulmonary embolism. All of these things are nasty. If you get a little one, that's your stall warning, as the aviation boys say. You deal with it. Right. Oh, I haven't got any treatment for that. I thought I had a treatment slide. No, I haven't. Right. How long have I got? 4 minutes. Very good. We can do cholesterol in 4 minutes. Biochemists need 4 lectures. Cholesterol. Picture of cholesterol. 2 6s, 3 6s and a 5, and different chains on the side. That's your cholesterol molecule. I don't expect you to reproduce this for me. Please don't. I wouldn't understand if you did. But notice how similar it is to some of the steroid hormones. This happens to be testosterone, because it's the one that Gorman and Stanfield used. I seem to have lost the reference. And you just notice that the side chains are different. This is now an oxygen with double bond instead of a hydroxyl. The CH2, there it's still the same, but these chains, that one is the same, and you replace this huge chain up there. Once upon a time I could have told you what that was called, by an hydroxyl radical. So that's a very small metabolic change. It's very easy to make those other molecules from that core molecule. Cholesterol, of course, is crucial in the cell membrane. No cell membranes, no function. So you produce cholesterol in the liver. It's the end product of fat metabolism, which you see. And it produces, the less of it you take in, the more it will produce because you need it. It's a transport molecule, and it goes into cells via receptors, low-density lipoprotein receptors. That's what LDL stands for, low-density lipoproteins. And it's regulated, its entry to cells is regulated by regulating the receptors and the intracellular production. So you're dealing with two things. So if you've got lots of cholesterol coming into the cells, it shuts down the receptors and it shuts down the intracellular synthesis of that. Now that can lead you to high extracellular concentrations, and that's where the problems occur. Again, Sherwood isn't particularly good on this area, the processing of cholesterol. So I've referred to Byrne and Levy again for those of you who want to have a bit more. Those of you who are doing biochemistry will have loads anyway. The rest of us don't need it. This is a very complicated picture. Please don't try to learn it. Please don't try to learn it. Right? It's just an illustration of the bits. It has all the components in. I'm not too interested in the middle bits. I'm interested in the edges. Here's our digestion of fats. That's a brilliant little picture. I might pinch that and use that somewhere else. Digestion of fats there. Absorptive cells, micelles, fat droplets, all of that going in there. All heading in towards the liver and coming out as chylomicrons, little proteins there, and there are the chylomicrons. And the density of those changes, those particles, they accumulate various bits of other lipoproteins and other elements of things. And there you talk about high density and low density. Now the density refers to precisely that, their density. The biggest determinant is the ratio of protein to fat. The more fat you have and the less protein, the lower the density. The lower densities are the bad boys. And you see them, there's very low densities, and there's a low density lipid coming in there, and that's showing it, how it accumulates as a plaque in our blood vessel, as we've seen before. There's the high density ones, that's processed by the liver, and that's fine. So one of the tests that is used for risk of atherosclerosis, the slide we've just seen, is the ratio of high density lipids to low density lipids. And if your ratio goes the wrong way, you've got too much LDL, lipoproteins I should say, then you get increased risk of atherosclerosis. Here's your treatment. Exercise is good for you. May ruin your knees, but it will reduce your excess cholesterol and help you to metabolize it. You can change your diet. Ingest less cholesterol. Take up eating things that mop up cholesterol. Oats, for example. So your porridge is a grand man if you don't have the whiskey on it and not too much cream. If you smoke, which of course none of you do, being good and virtuous and wise people, then stop. That's it and all about it. And then, of course, there are drugs which are there to keep pharmacists in luxury, which you deal with. And you can block the reabsorption of cholesterol at the terminal ileum. So it will then be excreted. So that can be one of the ways that there are drugs that do that, and you can explore that. I think there's the last, I think it's the last, yes it is the last slide, which says exactly that. You can block, if you've got hypercholesterolemia, that's too much cholesterol in the blood, then you can block that by blocking terminal ileum reabsorption. Look at that, spot on, tougher, you're a genius. Thank you very much, talk to you on Monday.